all recordings will be transferred to the NNLM YouTube channel for later viewing. Our opening keynote presenter today is Dave deBronkart, more famously known as ePatient Dave. ePatient Dave is one of the world's leading advocates for patient empowerment and engagement. He survived a near-fatal cancer in 2007 by being hyper-engaged. His convincing advocacy for participatory medicine led him to being the first patient blog captured in the National Library of Medicine's History of Medicine division. In addition, his message has received global recognition. He was the Mayo Clinic's 2015 visiting professor in internal medicine. His book, Let Patients Help, is available in 8 languages, and his TED Talk has been translated into 27 languages. Everyone, please welcome ePatient Dave.
Thank you, thank you. It's, I tell you, I am so excited that face-to-face conferences are getting started up again, that even though this one's virtual, I decided to get dressed up in a coat and tie as if we were going on stage. I mean, the energy is great. And I will say, Tony, that here in New England, this is the Boston viewed from the harbor in the background here. Wind chill is 15 degrees today here. So it's just really nice of you to show me the cherry blossoms that are happening in your neighborhood down there. I'm a little envious.
It's 21 degrees here today, Dave.
Oh, well, good. Now I feel better.
Good.
So let's see. Are we on screen share?
We are.
Yes, we are?
Yes.
Good. So I want to thank you for this opportunity. I'm always thrilled when I get invited back to talk about something new that's an extension of the patient empowerment work a lot of us have been doing for many years. And I'm going to be sharing today a recap of my cancer story that Tony mentioned, but then something new has come up in my life in the last year, and it forced me to think seriously about what did I learn and what have we been talking about in this movement, because there's a new real challenge to my well-being that's alive today. Nasty diagnosis, as I chose to call it. And let's talk about your future, because seriously, this is not just about what happened to me. One of my aphorisms is patient is not a third person word. This is going to happen to you in one way or another. And the question today is, what are you going to do about it? A quick review of how I came to be here. I was a very ordinary non-medical guy wandering through life. I worked in high-tech marketing for many years, and I'm a data geek. I like tech trends, automation, but there's nothing special about that. I am not medically knowledgeable. In 2007, as you'll hear briefly, I discovered I was almost dead and got better in less than a year. True story. And in 2008, I learned about the e-patient movement because my primary physician, luckily for me, was a pioneer of that movement. And I started blogging about it, and a number of things happened in 2009. And I ended up, by the end of the year, getting asked to give my first keynote speech at a medical conference. In 2010, I quit my job and went full-time. And in 2011, it went international. It's been a crazy ride. This is not the normal outcome after a near-fatal disease. My TED Talk was in 2011. And since then, there's been 650 events in 26 countries. It's great to be alive, is all I can say. Now, let's get down to brass tacks. This is an aphorism, but I'll tell you it is true. Knowledge is power. Knowledge is empowering. And access to knowledge has changed terrifically. In the book that I co-authored with my famous primary care physician, Dr. Danny Sands, shown here, notice how this photo was taken in 2009. He's still showing, he places the computer where we can both see it at the same time. If your doctor doesn't do that, ask for it, all right? Famous griping and griping about the doctor has their back to the patient. Well, ask, be empowered, ask to be able to see what's in there. One of the aphorisms is we can perform better if we're informed better. And the flip side of that is that it's perverse to keep people in the dark and then complain that patients don't know anything, right? So the defining question for this lecture is, what will you do and what could you do, given that you perhaps don't have any medical training or deep knowledge about the crisis that will hit you or your family? And I'll tell you, this is fresh for me now, because within the last few weeks, I learned that a close relative that I really care about has stage 4 pancreatic cancer. So it's off to the races again, learning fast when everything's on the line. This pioneering physician, Tom Ferguson, died in 2006 before my cancer case in 2007. And he created this website, epatients.net. He was a pioneer literally back in the 1980s of giving information to patients. And across the top there are a number of his colleagues, including Susanna Fox, who I'll be mentioning later, and Dr. Danny Sands again, right over his elbow. And on the far left is a man named Gilles Friedman, who's one of these crazy, brilliant people who started the patient network that years later helped save my life, okay? Ferguson was a true visionary, and he coined this term, e-patients, equipped, engaged, empowered, enabled. Well, as I said a minute ago, Dr. Sands and I, this was taken after my cancer. It was a publicity photo, but it's realistic. And in 2009, after the cancer, he and I were among that whole group there across the top of that picture, formed the Society for Participatory Medicine. And this is the evolving world. This society is not high profile, doesn't have any big grant from Robert Wood Johnson or anything, but they are onto something. Notice that the symbol here is a handshake. It's about sharing the work of healthcare. A short version of my cancer story. Early in 2007, and this is 15 years ago now, but I remember this vividly, I got a shoulder x-ray, and just for a routine stiff shoulder. And the next morning, Dr. Sands called and said, Dave, the radiologist called me, and I pulled up the image on my screen. Back then I said, can I see it? Well, there wasn't a way, but today we have it. He said, your shoulder will be fine, but there's something in your lung that shouldn't be there. And we have to find out what it is. Well, a whole bunch of drama and additional studies later, what we found was that it was a metastasis of stage 4 kidney cancer that had spread to my lung. I didn't feel sick yet, but the dumb luck of that shoulder x-ray exposed this tumor sooner than we would have known. Now, this is a generic diagram of stage 4 kidney cancer from the website of the drug that I eventually got. Totally by coincidence, it shows that thing in the lung. Also by coincidence, in the left femur, I had a big metastasis there. A couple months later, that leg broke from that tumor weakening the bone. That shows, the head shows a brain metastasis. Mine actually was in the skull. I have a moth-eaten area at the back of my cranium to this day. And additional tumors, 5 tumors in both lungs, 1 in my ulna. And if you look at the head, by the time my treatment started in April, I had a tumor erupting from my tongue. I had kidney cancer growing in my mouth. I was extremely sick, and the best available data, my oncologist correctly said, there's not a lot of good data on people like you, but I have a big appetite for information. So I hunted, and I found that the only study that I fit into said the median survival of somebody in my condition was 24 weeks. And I will tell you, ladies and gentlemen, this will focus the mind. All of a sudden, all the other things on your life's agenda just sort of disappear. And a moment like this, as I say, will hit you. So think about yourself in this situation. A pivotal moment. Remember that crazy guy I said who formed a patient network years earlier? Dr. Sands knew him. And when the biopsy confirmed that it was kidney cancer, Dr. Sands said, you might like to join this patient community. Now, this was 15 years ago, all right? And notice, this is what a modern doctor will do. He didn't say, stay off the internet. He showed me where to find the good stuff. Now, it isn't always this easy. As you'll hear later in this talk, sometimes it takes months of hunting, but what a moment this was. Within 2 hours of joining that community, say, I am not anti-science, I'm not anti-establishment, I'm not anti-medicine, I'm scientifically trained, but I don't work as a scientist. I'm picky about who I believe. Within 2 hours of joining this community, my patient peers told me, welcome to the club, nobody wants to join. We know what it's like. Now, aside from the scientific information in a disease, this is important because I had never known anybody with kidney cancer, and all I knew was most people in my condition were going to be dead soon. And here I am talking to people who got the diagnosis 10 years ago and they're not dead. This opened up a huge space of possibility in my mindset. They said this is an uncommon disease, find a hospital that does a lot of cases. Right? Now, mind you, that's important because chances are good that your local doctor may not be inclined to say, you might be better off if you went into Boston, as I did. Anyway, they said there's no cure, but this stuff called high-dose interleukin-2 sometimes works. When it does, about half the time it's permanent. They said, the patient said it usually doesn't work. But when it does, about half the time it's permanent. Here I am, voila. They said the side effects sometimes kill people. Don't let them give you anything else first. And here are 4 doctors in your area who do it. And I'm thinking, wow, let me tell you. So, and their phone numbers. From the point of view of the patient who has the problem, this is valuable information. And yet to this day, none of this exists in the peer-reviewed literature. It's a whole different dimension, a whole different world of the consumer, the patient, the citizen having the autonomy to pursue what they think is important. And there's an important point here that I'll highlight. The side effects are severe. We're going to come back to this in a moment. For me, long story short, I was one of the lucky ones. Here's a CT scan showing one of my 5 lung metastases. That tumor was the size of a golf ball in my left lung. And here it was 50 weeks later. The treatment started in April and ended in July, and the tumor kept shrinking. It's immunotherapy. And boy, is that stuff magic. For me, a huge moment. I'm a child of the 60s, a social revolutionary, power to the people and everything. And so I'm really attuned to social change. What's happening in the establishment? Are we making a dent? So when the BMJ came to me, formerly the British Medical Journal, in 2013 and said, Dave, we think your story should be published, I was like, what? Because I didn't go to them banging on their doors saying, hey, listen. The editors of the BMJ felt that what had happened through this patient community needed to be in the literature. And as a social change activist, I asked my oncologist, see, I could express the patient voice fine in the BMJ, but I knew that doctors would be reading this. So I asked my oncologist, what would you want other doctors to know about my story? And what he said surprised me. He said, you were really sick, and I don't know if you could have tolerated enough medicine if you hadn't been so well prepared. Now, what was he talking about? He was talking about the side effects. I had severe side effects, as the patients had warned me. And because I'd been warned about it, I had asked the oncology team, what do I do to prepare, to try to help myself survive? And they said, it's so funny, that's a good question. Nobody's ever asked us that. Now, here's a punchline. 5 years later, on a follow-up visit, they gave me a booklet they'd produced on side effects from kidney cancer treatments. They took what the patient community gave me. See, they didn't have an answer. So I turned to the patient community and I got 17 firsthand stories of what it had been like. And so for every side effect that hit me, I knew what was going on. Now, there's no guarantee that would save my life. But this is what Dr. McDermott at Beth Israel Deaconess has said years later. He has since said he wishes he could bottle the way I behaved and prescribe it to other people. So you can go argue with him if you want. So here's a big question. How can it be that the most useful information can exist? We are all trained to trust the peer-reviewed literature. Heaven knows in the last 2 years, it's been all over the news. Listen to the scientists. Well, how can it be that relevant information can exist outside those channels? The number one answer is that knowledge is power, and access to knowledge has changed forever, okay? Social media, we have this lovely kumbaya, we're all connected, 6 degrees of Kevin Bacon diagram, but it really is like information capillaries. Social media connections are like capillaries in the body that can carry information nutrients to the point of need. And if you need, I encourage everyone to go to SusannaFox.com and watch this extraordinary 10-minute video. There is years of wisdom that is wrapped up in this super video. And this is exactly the way I felt, all right? I had never known anybody who had kidney cancer, and then there's a whole bunch of them. And this is also exactly what hit me 1 year ago, because now I'm gonna shift to the new lesson where I had to apply all of this again. There's this funny line, right? It's all fun and games till someone loses an eye. Well, so this is Your Time Will Come ophthalmology edition for me. Like many people my age, I got cataracts in my eyes. You know, the lens gets cloudy. And this is something, there are 6 million cataract replacement operations per year in the US. And what they do, and when this goes well, it only takes 10 or 15 minutes. It's amazing. They go in and they slit open the little the little capsule, the little bag that holds your lens. They break it up with ultrasound and suck out the fragments, and they stick in this amazing replacement lens. That's great. You walk out and boom, some people don't need glasses anymore. It's really amazing. However, sometimes this happens. Sometimes the little capsule that holds the lens breaks and pieces of the lens fall out through the back of the thing. You're lying there on the table and these fragments start drifting down to the back of your eyeball. Now, half the time they're able to quickly rescue them, but the other half of the time you have what happened to me, which is called posterior capsular rupture with retained fragments. And this cannot be. What they have to do in that situation, whenever the capsule is ruptured, they have to put the replacement lens in this little fold in the structure of the eye called the sulcus. So that lens with those S-shaped arms on it, instead of being at the right place, now lives a little bit farther out from the center of the eye. You might imagine that I got really curious about this, and I couldn't, looking through all the information on the doctor's websites, I couldn't understand it well enough. I solved my problem for 18 bucks on Amazon by buying a model eyeball. This thing's about 10 inches wide, and you can pull the pieces out. You can see where the lens normally is, and you can see that little indent, the sulcus where the lens is. A significant problem is that the lens is no longer at the correct focal length. All right, we will get to that. Now, to get back to the surgical problem that hit me, as I Googled like crazy, all right, it turns out that this posterior capsular rupture with retained fragments is called in the literature a dreaded complication. How's that? That's about as much fun as reading that your median survival is 24 weeks. And I'm not the one calling it that. There are multiple articles, a dreaded complication. There's another article, Capsular Rupture as a dreaded complication. All right. On top of that, how often does this happen? 1 to 5% of all cases. 6 million cataract procedures per year. 1% of that would be 60,000 of these, 1,000 of these capsular ruptures a week or more. Now, so I'm going along, I'm getting my eyes adjusted. I'm learning to live with this and trying to wait for my vision to stabilize before I get new glasses. This all happened in September. A delightful thing, by the way, you know what? They can't just leave those fragments in your eyeball floating around down to the back. So you know what they have to do? They go in, they literally vacuum out your eyeball. They suck the vitreous humor out of your eyeball, empty, and then fill it up with saline. I did not realize, I thought the eyeball was just full of some jelly stuff. No, but it's a constant plumbing thing. There is new fluid coming into the eye and then draining out. And it turns out if the drain gets clogged, your eye pressure builds up and bad things happen. I discovered in January that part of my optic nerve had been killed. I had another thing happen. And I got steroid eye drops. When that happens, they're supposed to check the pressure to make sure the pressure isn't building up in your eye, and they didn't. 2 weeks later, I had switched to another downtown Boston eye doctor, and they said, okay, your macular edema is doing okay, and by the way, you've got glaucoma. And I didn't just have glaucoma, because glaucoma doesn't necessarily kill parts of the nerve. But when we did this Humphrey visual field test, it turns out that 30% of my optic nerve in that eye is dead and will not be coming back. And so once again, now, and when this starts happening, it can progress rapidly. In my case, it hasn't. But again, I wanted to learn like a fire hose. I captured a whole bunch of things that I learned on a glaucoma page on my website. And of course, you can imagine I was hunting for a good patient community. It took me close to 6 months, but I finally found a fabulous group that's nearly invisible because they have put zero effort into SEO, search engine optimization, being findable on the internet. A gift to you folks, fiteyes.com. There are 3 parts to the website. It's a fabulous community. And I will share with you a couple of things I've learned from them that has altered the course of my living with this condition that I now have for the rest of my life. One thing they have is something called Ask Fit Eyes. And I asked this question as I was exploring there. I thought I heard of normal tension glaucoma, and my impression has always been that glaucoma is high IOP, intraocular pressure, but it turns out that's not true. So I asked this question and got a bunch of answers. And this is one of my aphorisms in the book is patients know what patients want to know. And if you don't remember to ask it of the doctors at the time, why would they spend time necessarily educating me on this stuff when it's not part of my problem? Well, in a patient community, just as Susanna Fox's video talks about, patients talk about what they want to talk about. It is the essence of patient-centered healthcare. Another big topic of discussion is, why do eye drops suck? The only way to treat glaucoma, to monitor and treat glaucoma, is by tracking the IOP the eye pressure, and treating it with eye drops. Well, I don't know if you've ever needed to get medicine into your eyeball using eye drops, but this is a terrible thing. Commonly, people spill the drops down their cheeks. Some people refer to it as washing their cheeks. Why hasn't the industry done better on this? On top of this, ProPublica 5 years ago did an expose that those drops come out in too big, so you may get too much medicine into your eye. There was a big furor around this. Nothing has been done about it, folks. So some of us have decided to become more careful. I brought this up to my oncologist, or not my, excuse me, my ophthalmologist in Boston, and to his credit, he wasn't aware of this being a big deal, but get this, he said, I did some research. There's a gap in the published literature about the efficacy of this. So I'll share some of the better articles I found. Look at this, these highlighted articles. This article says people having difficulty with eye drops 50% of the time. And another article said, if you do follow the definition strictly, 90% of people were unable to do it the way they prescribe. And what has been done, that 90% article was published in 2012. Okay, what has been done about that since then? Not a thing. The industry has not stopped what it's doing. They keep prescribing. Well, in the Fit Eyes community, I learned about a thing called Magic Touch. It's this little rubber thing. Normally, I just took this picture this morning. Normally, you put this on your fingertip and you put a drop in the little cup at the top, and you just poke yourself in the eye with it, and the drop transfers reliably. Something like $12 or something. The doctor did not know about it. This is like a replay of a movie I've already seen. And of course, I'm sharing this with the practice I use in Boston is called OCB. I highly recommend them. It's funny though, because in one of my first visits there, one of the doctors, with all my questions, said, it's not our job to give you a PhD in our field. And I was like, uh-oh, this is not going to go well. So I actually sent him a paper letter, including a flyer from the Society for Participatory Medicine, and they are on board now. Now, the other thing is measuring, and this is the same as with people with diabetes who have to check their blood sugar. Measuring your IOP, intraocular pressure, is important. But I go there in March, I get measured, 4 in the afternoon. I go there, then they give me some medicine, and I go there in April or May, and I get measured at 10 in the morning. And this is sort of like a person with diabetes taking measurements every month or two. It's ridiculous. It turns out there is now a gadget. It's not covered by insurance. It's ridiculously expensive. I paid $2,700 for this. It's my vision that a home device like this will become affordable for everyone. And I'll tell you why. I will tell you why. Here is a graph of the data from this device in its app. The yellow band is the normal range. Okay, and the target line for me is 16. You can see that blue line across there. And it turns out in a given day, I may bounce from 9 to 27 or 23, something like that. And I'm thinking, as somebody, I mean, I've done plenty of measurements when I worked in a factory. And so I'm thinking, this is nuts. Here's an example. So let's say they measure you at the 2 times that the arrows are pointing to. All right, well, let's see, it was 22 there. That's pretty high. We got to watch out for that. And then a month later, we measure again and it's 10. It's like, dude, the eye drops are perfect. They're terrific. Here is that same graphic if they had measured at a different time of day. Exact same data, completely different picture. So I'm thinking, it's doing it with an occasional visit in the doctor's office is just plain wrong. Fortunately, so I thought, yikes, I have those big spikes. I discontinued caffeine And it turns out that the spikes still stayed there because the pattern was that in the morning it would shoot way up. Another thing that was discovered that we had never would have seen without this home device, right? The pressure's been trending up the past week. He warned me that the evening eye drop that I have loses its effectiveness after 6 weeks. If I hadn't been checking it at home, we would have had no way to know this. So, and since this whole NNLM event is about research, I want to close by touching on some specific things where you can tell patient autonomy comes from, number one, having information, number two, being listened to. And the big next stage that we are entering is who gets to say what priorities should be pursued. Just a couple of weeks ago, on the NPR Daily Science podcast, Shortwave, this man was featured. He used to run mental health at NIH, if I recall correctly. And a patient in the audience at one point responded to one of his scientific presentations by saying, "Our house is on fire and you're talking about the chemical composition of the paint." The scientists are doing what the scientists want to, while the people who have the problem, the man who said that has a son who's got multiple suicide attempts, all kinds of things, right? And it reminded me of back in the 80s when AIDS patients acted up and said, "Quit doing your long-range biological crap, fix our problem." Well, and here's a friend of mine, a German scientist who is now working in Sweden, I believe, and her husband had died of malignant melanoma. And as she discovered, she saw, so this is the standard cascade. You start with a clinical question and you work through. And her point was patient involvement increases now as the work progresses as defined by the scientists. And what she was calling for, and that's making sure patients are doing things right. What she was calling for is for the patient voice to be earlier in the pipeline, which amounts to making sure researchers are doing the right thing. And just 2 days ago, a brilliant new development of this popped up. As it turns out, a college friend of mine, Janet Freeman Daly, her life was saved 10 years ago because she had bumped into me at a college reunion and learned about ACOR. So when she got diagnosed with lung cancer, she found a patient group and things went along well. Well, as it happens, she and colleagues have this new paper that was just published and this is perfect, from backseat passenger to co-navigator. Patients actually being involved with defining the direction of the research. This is the new world we're heading into. And just to wrap up, I want to summarize how this unfolded in my life. December of 2006, this was New Year's Eve, just before I got that shoulder x-ray that revealed I was dying. This is a guy who was dying of stage 4 cancer and didn't know it yet. 10 months later, I was diagnosed in January. The kidney came out in March. The treatment started in April and ended in July. 3 months later, I haven't had a drop of anything since. When immunotherapy works, it is a beautiful thing. So by October, the office Halloween party, I was very happy that somebody snapped this picture. All right, this is me grinning at the ghoul, significantly leaner and less hair. A year and a half later, this was me laughing with my mother on the day when, heck with it, I've got reason to be emotional and happy about this. I got to walk my daughter down the aisle. And then a couple of years later, I got to become a grandfather. And who that baby girl has become, here she is during the Olympics. You know, a photo that her father put on Facebook. Empowerment matters. and knowledge is power. From the bottom of my heart, I know this is coming to your life, your family, my question. So let's discuss, let's move to Q&A. What do you think about this? BJ Fogg, a great behaviorist, has a question that he uses in his lectures. What surprised you in this? What did you hear that surprised you? And most important, what will you do when your time comes? And Tony, I'll hand it back to you. We can go off screen share if you want, or whatever you'd like.
It's completely up to you if you'd like to stop sharing your screen or if you'd like to keep it on this page. But I do want to thank you, Dave, very much for your very personal and engaging presentation. I'm sure that there were a lot of people that were tearing up a little bit here and there as well, just as I was actually. But we do have about 20 minutes or so for questions. So if people have any questions at all, please feel free to use the chat feature. If you'd like, you can send it to just the hosts and panelists or to everyone. I will try and catch everything as it comes through. I do note that there was something that happened a little earlier. Cecilia had asked, is this something like Patients Like Me was before it was sold with the patient advocacy or the patient engagement website that you mentioned before?
Well, so it's pretty self-explanatory. One aspect of Patients Like Me is patient community. What you really, if you are like me, you want to find people like you that you can connect with. You know, Susanna's video, and that's one of the things you could do there. Now, they had additional things they did. They did huge amounts of data collection so that they could run their own clinical trials. But that's different from what Janet is talking about, you know, or Bettina Rill, you know, defining what should be studied in the first place. But they certainly are a great example. The thing to think about is, so what's happening here? Somebody has a problem. Traditionally, they have had to turn to the wizards, you know, the people in the ivory tower, because they themselves had no access to information about what the condition is, what the treatment options are, and so on. And that is profoundly no longer the only path that's available. It's also clear to me, not everybody wants to be empowered. To some people, when the crisis hits them, the last thing they want to be told is that they've got a whole bunch of new skills, right, to take on. Right. And some people have felt that they were told, well, if I die, you're going to blame it on me. No, 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 no. This is entirely about altering what's possible, not what people have to do. My point is, if somebody wants to be involved, please, let's give them a way to pick up a shovel and do what they can.
Someone had mentioned to me that one of the papers that you had shared was also co-authored by a medical librarian we're all familiar with. Her name is Patricia Anderson.
Of course.
Yes.
P.F. Anderson.
Yeah.
Yes, of course.
So,
yeah, but I have on numerous occasions. I just love MedLibs. I love what they do. There's Nikki Eagledog, right? A good friend online. And really, really, I really hope that MedLibs will consider inviting the general public, right, to learn more, be a guide into this arcane literature. Yes, absolutely.
So there's a lot of wonderful chats, comments from people saying to thank you for your empowering story and everything as well. There is a question that Jessica had mentioned. Do you know what patient platforms are available to cardiac patients, or more specifically, heart failure patients?
Oh, you mean like what kind of patient groups?
Yes.
No, I do not. I wish somebody would give birth to a great big grant to build a catalog of these. On my website years ago, I tried to maintain a list. It's at epatientdave.com/communities. but it was a lot of work and I had no capacity to check them out. But please, if you find anything, let me know. As I say, it took me months of really motivated searching just to find fit eyes. Oddly enough, until I found fit eyes, the best community I found was on Reddit, which is like the home of QAnon and 72 different flavors of stupidity, in addition to Einstein fans. Crazy place.
Thank you for that commentary. I won't comment or add to the Reddit discussion. So Kate has a question. I'd love to hear your thoughts on patient advocacy focusing on long COVID and community advocacy focusing on airborne-oriented mitigation in the pandemic. Where are people getting information to power these movements? Who is getting information and who isn't? It's a lot of questions in this one. Who is getting, how is trust in medical authorities affected by these processes?
Oh boy, so
it's a long question.
All of that boils down to a whole separate follow-up session. So seriously, Tony, I hope that these questions will all be captured, because I'll be happy to, like as you know, I published a blog post about this event. Any of these questions that people drop in comments there, I'll pursue. So I'll give a quick answer in the interest of time to each of those. What was the first one?
The thoughts on long COVID and community advocacy on airborne-oriented mitigation.
Long COVID first.
Yes.
Consider that long COVID was denied until the patient community made the NIH pay attention. All right, and to their credit, the NIH did pay attention. By the end of that first COVID summer, they had recognized that it was a real thing. And they engaged with actual sufferers to help define what is this freaking thing. Okay, so this, when you are in the old days, the rate of new knowledge was an order of magnitude less than it is today. There's a fabulous book that librarians might like. It's called The Half-Life of Facts. And in healthcare, the rate of expiration of valid knowledge is worse than any other field, according to that author. So it used to be that only and this was part of the transition away from snake oil and quackery, was that only scientists were allowed basically to define what a condition was. And we have now gone to the point where the delay, the time lag, in Tom Ferguson's famous manifesto, the e-patient white paper, he talked about the lethal lag time of how long it takes for new knowledge to reach everyone in the field. There's another lag now that points in the other direction, which is from the moment when patients are talking about a reality with each other until science catches up. So we are in a time of change, inversion, and so on. What was the next question?
Let's see, where are people getting information to power these movements? And who is getting information and who isn't? Last part, I can wait until the last part.
Yeah, so where are people getting information? God help us, they're getting it from the internet, ladies and gentlemen. And sure, everybody needs the ability to detect what is garbage and what is not. And the hell of autonomy, the hell of democracy is that if you let everyone vote or make up their own mind, there are going to be some people who you think are crazy. And it's not a joke, all of one of the things we're working on in the health data world, there's a new software standard called FHIR, F-H-I-R, for moving data between hospital computers and apps. And it's federal policy now. Well, one of the projects that the Patient Empowerment Work Group is working on is patient requests for corrections, okay? With these emerging apps that will let you look at all the data from all your hospitals, you're gonna start spotting mistakes, right? And you'll be able to say, that's wrong, I'm not using that medication anymore, and so on. Some people thought that we would just let patients directly edit the information that's in the hospital chart. No, 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 no. Remember the people in South Dakota who denied they had COVID right up until their death in an ICU. The clue here, and this medlibs can make a huge difference here. Thomas Jefferson supposedly said, when citizens are well informed, they can be counted on to govern themselves. Well, that's a big if, because if you've got people who aren't well informed, but you are, ladies and gentlemen, you are in the middle of a social revolution right now. Step up and be a force for good.
So the last part of this question is, how is trust in medical authorities affected by these processes?
And so it turns out, and that this played out spectacularly in good and bad ways during COVID the last couple of years. Trust in medical authority among well-informed people hasn't shifted much. The thing that is under severe attack is the whole concept of authority, right? The idea of, I'll be the one who decides, I'll tell you what's important, right? I had one doctor, one of my speeches in St. Louis a few years ago, got up on a panel after me, and he was an august senior physician at Barnes Jewish Hospital in St. Louis, which is sort of the Mass General of St. Louis. And he looked at me from the stage as I was sitting there in the audience, and he said, if you want to know who the best surgeon is, I'll tell you. Don't get that from some blog. And he spat it out. Well, and I thought, I actually tweeted, look, mommy, a dinosaur. The problem is that as people become savvy and they encounter doctors whose knowledge is out of date, and it's one thing if we all admit that the correct answer keeps evolving. It's a very different thing if somebody just insists that they know because they know. In my case, after the new eye doctor in Boston said, secondary glaucoma induced by steroid drops. Okay, I went back for a different occasion to my local small town ophthalmology practice, and they were mad that I had gone to Boston. They were huffy about it. And the doctor I saw on that day said, it's ridiculous. It takes months for that to happen. Well, I brought that back to the Boston doctor, and he said, well, that's what we used to think. But for the last couple of years, we've known that this reaction can happen in a small number of patients within a couple of weeks. So who's the authority here? You got the people who think they're the authority. The reality is that humility is a really strong part of what it takes to be a great knowledge owner. So what's happening with authority is, and anyway, subject, well, that's a whole separate keynote.
You have more,
but it's a great question. Authority, competent authority must be open to realizations that things have changed.
Yeah. Just so you know that there's like 15 more things that popped up. So in case we can't get to your question, everyone, I will save the chat.
Let's see if I can do one-liners. Go for it. This is the lightning round.
Okay, it's so good to be reminded of the positive and good aspects of the social web. The past few years have seen a change towards the negative on many platforms. Have patient sites managed to avoid this? And she adds, I do hope so. And this is from Sally.
Well, the good ones moderate their content. That's all I can say. Next.
Okay. Denise says, do you think that telemedicine is allowing patients to identify and engage with physicians who may be willing to work collaboratively with them? They no longer have to confine their interactions to physicians in their local vicinity.
I think engaging with others is a separate issue from telemedicine, which is access to visits, both of which I'm highly in favor of.
For folks who do not have Society of Participatory Medicine Science letterhead to present to doctors when a patient shows they've done research and ask relevant questions and the doctor is not receptive, do you move on to another doctor or try to work with them?
So there's a whole bunch of practical reality here. And I don't have SPM letterhead. What I gave him was a brochure that, if you will remind me, I'll post a link to it in the comments on my blog post about this, because it's a downloadable PDF, and it just spells it out in a quick hit.
Okay.
And yes, you betcha. That's what I did. I left them. They were wrong and they wouldn't listen to my questions.
I will add that I too have changed doctors that I was frustrated with. So,
but not everybody can. You may not
true.
have other choices.
That is also very true. Do you find, or have you heard, that support groups do better or worse because of the sponsor, such as drug company portals versus nonprofit organizations?
I don't have any data on it. It's very clear to me, and purely anecdotally, I've heard of numerous cases where if an organization is sponsored by any company, there is an incentive for the employees, unless it's an all-volunteer group, right? There's an incentive for the employees to be careful what they say. Folks, when you need information, you got to go find information, but always have your eyes open about how might this be wrong.
I scrolled through a bunch, but here's one that I thought, Lisa asked, any thoughts on advocating for yourself within a medical insurance industry that is often driven by profits and not what's best for the patient?
It is, in the United States, the great perverse challenge. I have a 10-point, as it happens, the question that you just pointed to is exactly why I blogged, why I decided to try to move my data back in 2009 into Google Health, which ended up revealing that there was a lot of garbage in the data and so on. And I have a 10-part blog series that I did a couple of years ago that led to my getting involved with the FIRE movement, because trust me, and I'll link to this series again, trust me, you are not soon going to alter the structure of the American health system. It's including that the power is with the insurance companies largely, the people who control the flow of money. And year after year, as the money gets bigger, it gets to become harder and harder to stop that, which is precisely why I said back in 2009, when I was asked to give my first talk, I said, give me my damn data, because I want to be able to manage my own care regardless of what I can get through insurance or not. And that's what FIRE is beginning to make possible, subject for another day.
I don't know if you'll have time for this particular question, but as a follow-up to an earlier one, do you have any comments on Adelhelm Biogen and the Alzheimer's Association?
No.
Okay. So there's a lot of wonderful commentary for you that I've saved in the chat that I'll be happy to send to you following this presentation. But I think that may be it for actual questions that we'll cover. So I do want to thank you, Dave, for your time to present to everyone. I also want to thank all of our attendees for taking the time to attend our first keynote presentation today. Thank you for sharing that eye. At 1:15, you have the option to attend one of two live presentations, The Journey for Health for All, featuring panelists from Northwestern University Center for Health Equity Transformation and the Chicago Public Library, or Turn Community Curiosity into Real Scientific Impact with SciStarter in the National Library of Medicine, featuring Carolyn Nickerson. Regarding evaluation of this program, at the end of today's final keynote, you will see a tab added to the conference platform labeled Evaluation. You may need to refresh your browser to see that particular tab, but clicking on that link will take you to a REDCap evaluation evaluation page. And after you've completed the evaluation, you will see all of the steps you'll need to earn your 10 MLA continuing education credits. Thank you all, and we hope you enjoyed the rest of today's presentation. And thank you, Dave, for taking the time to tell your very personal and very engaging presentation. I really personally appreciated it.
And thanks for having me back. And just to make sure everybody's clear, my eyes are doing well. I'm now 6 layers deep into figuring out how to get modified eyeglasses to cope with my new reality. But yeah, it makes a difference when you know what's going on.
Yeah, I got my new pair of glasses yesterday and I couldn't see out of them. So I need to touch base with my optometrist.
Thanks, everyone. Take care.
Bye, everyone, and have a wonderful afternoon.